Department of Medicine. I, Dr. Sunil Kumar Bhatwa, Associate Professor, Department of Medicine. I welcome you all on this inaugural function and for the CME on acute abdomen. Without wasting so much time, I would like to invite first of all Dr. Sanjeev Mashri. He is Senior Professor from the Department of Medicine. Dr. D.K. Kapoor, Professor Surgical Gastroenterology from NGMPH, Jaipur. Dr. Rajat Bhargav, Associate Professor, Medical Gastroenterology, NGMPH, Jaipur. Dr. Ajay Sharma, Professor, Surgical Gastroenterology. Dr. Ramesh Chandra Verma, Pediatrics, and Dr. Priyanka Goyal, Assistant Professor. Dr. M.P. Sharma sir, Professor and Head of Department for Gastroenterology, General Medical College and Bay. Dr. Purnima Pacholi ma'am, Senior Professor, Department of Gynecology, and Dr. Shyam Gupta, Senior Professor from the Department of Surgery. Thank you all for coming, and first of all, I'd like to invite Dr. Rita Bagri ma'am.
I welcome Dr. Jyotirmay Paul, Dean ICT, and Dr. Manish Mathur, President API India, virtually. Thank you, sir, for joining us. Thank you.
Thank you. First of all, I'd like to invite Dr. Geeta Bagri ma'am. Sorry, Geeta Bagri ma'am, to facilitate our today's speaker and chairperson. Please, ma'am. Dr. Shyam Gupta. Dr. Yuval. And Dr. Sunil Mashri. Dr. Bachchan, Dr. Yadav,
After greeting Dr. Priyanka by Dr. Mashri. Thank you, everybody. I request Dr. Manish Mathur sir to please bless us by your words of blessing. Dr. Manish Mathur sir. Yes, you are audible, sir. Yes, sir. You are audible, sir. Please carry on.
Medical College and the esteemed faculty, Dr. Rajat Bhargav, Dr. Priyanka Goyal, Dr. Dr. Ajay Sharma. It was a pleasure and privilege to extend a warm welcome to all of you on behalf of API and ICT and this CMA, organized jointly by API ICT and Department of Medicine, JNM Medical College Brisbane. Acute abdomen is a medical emergency and needs urgent attention and treatment. And many times the both at diagnostic dilemma and proper understanding of approach and management of acute abdomen is very essential for our physicians. I compliment and congratulate Dr. Mashri who has chosen this subject vital interest for all.
you so very much, sir. Thank you. Your words are always encouraging and a guideline for us. Thank you so much. Now I invite Dr. Jyotirmay Paul, Dean ICP, to say a few words. Dr. Paul, sir.
Yes. President API, Dr. Manish Mathur, Principal, Acute Medical College, Dr. Sanjeev Maheshwari, Additional Principal, AGD Medicine, and all the esteemed faculty and delegates. It is really my privilege to be present at this online in the academic program conducted by API Rajasthan Chapter and Acute Medical College. Becoming the dean, I give a call that ICB program, as an API program, should be mostly conducted from the medical colleges rather than transfer college. And Acute Medical College responded to my call very meticulous. I am also happy from the other aspect that I am seeing almost every week or fortnightly they are picking up the subject of clinical importance. Diabetes and dyslipidemia is the most prevalent subject discussed across the India, but they have taken the most important clinical issues. As I am dean and also from medical educational service, I realize that this aspect, the clinical aspect, acute abdomen, chest pain, dyspnea, that should be discussed deeply in different form and case discussion and importance of the procedure. This should be our aim of API and ICP. And I am very happy Sanjeev Maheshwari and the entire team of Acute Medical College and Rajasthan API has taken the shoulder to carry forward the dream of API and ICP. I wish all success of this program. Thank you.
Thank you so very much, sir. We are always being encouraged by your words. We know that you are true academic and you are at least interested in postgraduate teaching. We are witnessing that many a times. We also admire the program which you will be conducting in 12th and 13th exclusively for the postgraduate. Thank you very much for blessing us. Thank you very much.
Thank you very much, sir. Now, before starting the meeting, I request Dr. Sanjeev Maheshwari sir for
Dr. Girish Mathur, President API, Dr. Jyotirmay Paul, Dean ICP, Dr. V.K. Kapoor, Dr. Rajat, Dr. Ajay, Dr. Priyanka, Dr. M.P. Sharma, Madam Purnima, Dr. Sham, and all faculty and dear students, and Dr. Sunil Gurwal too. I am delighted to welcome you on this afternoon for a very important topic as mentioned by Dr. Jyotirmay Paul, acute abdomen. Mostly we come across the patient with the symptom, not the disease. Patient only tells the symptom and we have to find out the disease out of his symptom. And acute abdomen is almost daily in and out problem faced by the clinician like anything. Maybe a gastroenterologist, maybe a physician, maybe a gynecologist, maybe a surgeon, maybe anybody, pediatrician also. And sometimes pediatric patients are not able to tell what they are suffering from and their parent also cannot identify the disease. It is you who have to identify the disease and treat accordingly. And in this matter, acute abdomen is a very important symptom. And I thank Mahatma Gandhi team for taking this symptom, and I was immediately delighted to continue with this symptom, and it is something very, very important for us. I thank you, our principal, Dr. V.B. Singh sir, for allowing us this to conduct this CME, and I am also thankful to everybody who are present over here to participate in this CME. Thank you very much.
Thank you, sir. Now I request Dr. V.K. Kapoor sir for word of blessing.
Good afternoon, everyone. First of all, I would like to thank JLN Medical College, Ajmer, and Dr. Sanjeev Maheshwari in particular for accepting our suggestion to organize this CME in the college campus. I am also very happy that President API and Dean ICP could join online. And the topic, as has been highlighted by Dr. Sanjeev Maheshwari, is of great clinical importance because whenever any one of us, whether we belong to medicine, pediatrics, gynae, surgery, are posted in the emergency services of any healthcare facility, we do see a large number of patients at various ages with the complaints of acute abdomen. And that is why both I and Dr. Maheshwari agreed to the first instance only that this would be an appropriate topic as the theme of this CME, which involves at least these four major specialties of any medical institution. And to deliberate on this topic, I have chosen a team which includes gastroenterologist Dr. Rajat Bhargav, pediatrician Dr. Ramesh Perwa, gynecologist Dr. Priyanka Goyal, and a GI surgeon Dr. Rajesh Sharma. We may not be able to cover the entire spectrum of acute abdomen, but I requested my four eminent faculty colleagues to highlight some of the important aspects related to acute abdomen. So I think we will start with Dr. Rajat Bhargav, who will tell us the role and importance of various investigations, including laboratory and radiology, in elucidating the diagnosis and then planning the management of a patient with acute abdomen. Slide control. Slide.
Good afternoon, respected teachers and my dear colleagues and students. So I'll just start the CME today, and the topic allotted to me is related to investigating acute abdomen. I'll just start with an approach to these patients with acute abdomen. So I'll go through my small presentation. The first thing we should know that whenever a patient comes with acute abdomen, we should think in terms of the quadrants of the abdomen, whether it is the pain in the right upper quadrant, left upper, right lower, or left lower. We can divide it into 9 regions also, like epigastric region, periumbilical, pelvic, and lumbar hypogastric regions. So anything that is an acute condition which has an abrupt onset, presenting with pain, which may be due to inflammation, perforation of a viscus, obstruction, infarction, or any rupture, presenting to emergency in a previously healthy person, it requires emergency intervention. So that is the definition for acute abdomen, and it encompasses a lot of conditions ranging from acute gastritis to hepatitis to very severe conditions like rupture of abdominal aortic aneurysms and intestinal perforation. So coming to the basic causes that we have to think and evaluate. So when the patient has a pain in the right upper quadrant, we always should think of diseases related to liver, biliary system, pancreas, which may include acute cholecystitis, hepatitis, liver abscess. Another important thing is whenever the pain is there in the upper quadrant, we always should think to rule out pneumonia and myocardial infarction. The inferior wall MI can have a presentation of pain in this upper abdomen. When the pain presents in the lower abdomen, we think of diseases like appendicitis, regional enteritis, Meckel's and Seeker diverticulitis. The causes related to the female reproductive system, the rupture, ectopic pregnancy, and ovarian cyst will deal in different talk. Then we have diseases like hernia, which may get incarcerated and strangulated, mesenteric adenitis. Similarly, if the pain is in left lower quadrant, we again think of the sigmoid diverticulitis, various gyne-related causes, and swascitis. Some diseases like acute gastroenteritis, intestinal obstruction, The occurrence of mesenteric ischemia or mesenteric thrombosis, acute pancreatitis, sickle cell crisis, they all can present with diffuse pain. In addition to these peritoneal and the GI disorders, a lot of systemic disease like diabetic ketoacidosis, porphyria, sickle cell disease, they also can have a presentation of acute abdomen. So whenever we deal with these patients, we have to think of all these causes. Before going to investigations and the imaging aspects, we should take a good history as the basic regarding the location of pain, in which quadrant it lies. Duration is important. Short lasting are usually the colics like renal colic, biliary colic. If the duration is long, there is radiation to back. Think of diseases like pancreatitis. Again, the character of pain is important. It is colicky when it comes to the intestinal colics, but the character may become deep and boring and radiation to back when it comes to pancreatitis. Sometimes various aggravating factors like food and all and relieving factors are helpful. Radiation is also very important, like the pain of appendicitis, it starts initially at the level of obliquus and then it goes to right iliac fossa. Referring of the pain to the tip of the right shoulder that indicate the biliary origin. With the pain, we have to think of the symptoms what the patient presents. Like if there is a lot of bilious vomiting, we think of more obstruction, presence of diarrhea, altered bowel habit, constipation, they all are important. Then age, again our differentials changes when if the patient is young children, then we think of causes like intussusception. Similarly, a female will have different causes as compared to male when it comes to lower abdominal pain. Patients with comorbidities, immunosuppressed patients, they may not mount the typical immune response and typical features. Previous surgery, there is more chances of adhesions and intestinal obstruction. Similarly, the history should be taken regarding various medications, addictions and family history of malignancies because they can also present with acute abdomen. Basics again, we have to do look at the facial expression and the degree of agitation the patient is having. A patient with peritonitis, rupture of viscus, he may have a very agitated look and he may not be able to lie down properly because of the severe pain. And the vitals are very important because if a patient comes with acute abdomen, he has tachycardia, hypotension, tachycardia, that means he has an imminent thing to intervene. Mostly they need surgery as well. So we have to do a good abdominal examination. We have to inspect the abdomen for presence of any distension, previous scars, because they may give an idea that patient may be having adhesion leading to obstruction. Look for hernias because again obstructed hernias can present with acute abdomen. We have to look like signs of peritonitis like guarding and rigidity, rebound tenderness for organs like appendix. Go for auscultation where in aneurysms we can have Louis and absence of bowel sounds or exaggerated bowel sounds depending upon the cause. Coming to the investigations, whenever these patients comes to us in emergency or they are getting admitted, we have to send a complete blood count to look for leukocytosis, which is common with sepsis and other conditions. Renal function test, again they help to assess the hydration and the renal function, as well as we have to plan a CT abdomen in all these patients. When we are dealing with some liver cause like hepatitis, liver abscess, cholangitis, CVD stones, so we have to go for liver function test. Amylase lipase to rule out acute pancreatitis. Coagulation test because most of these patients we may plan an emergency surgery or maybe some type of cholangitis ERCP-like procedures. So we need to have all these bleeding coagulation parameters. Lactate LDH when the cause of the patient getting admitted, if there is an elderly patient, we may have acute mesenteric ischemia, bowel ischemia going on. Those patients have really limited signs of abdomen. They have mainly the symptoms and the blood lactate levels and the LDH can help us diagnose. Patients may have the complaints related to renal disease like hematuria, pyuria. So a urine routine has to be done. Beta HCG again related to pregnancy, ectopic pregnancy. In acute settings, CRP and ESR have limited role to play because in chronic diseases they are usually elevated and their elevation in acute disease may not be of that importance. This ECG again, I have already told that if the pain is there in upper quadrants, we should always think that patient may have a old age patient and inferior wall MI, like the ECG showing changes in 2-3 kVA. So this is a very important thing because again we have to take a very rapid action. In emergency, we have to start with the basic investigations like chest X-ray, which can first give an idea of ongoing pneumonia, effusion, diaphragmatic irritation as a cause of pain. This presence of free air under the both lobes of diaphragm indicates a perforated viscus. It can also be present if post-surgery patients as well as because of some bacterial infections, but perforation or rupture of a viscera is diagnosed with these standing X-rays. Diaphragmatic hiatal hernia and the rupture of esophagus. Sometimes we have a spontaneous esophageal rupture and that present with an air in the mediastinum, in this area of the mediastinum, and that is seen in bore heavy syndrome. So with the abdominal X-rays, we can look at the most important thing is the bowel obstruction. We can go for a look at renal calculi and gallstones, dilated colon. This is showing pneumobilia, but as the stone passes from the CBD, there is presence of air in the biliary tree. This is a normal scapulogram of the abdomen or the X-ray, which is showing the normal distribution of the air, presence of air in the rectum. Whenever there is absence of the air in the rectum and dilatation of the bowel loop, so we can get it immediately in emergency. All patients with acute abdomen need to do ECG and with lower abdomen and X-ray abdomen to rule out bowel obstruction. This is showing a dilated bowel loop in the upper abdomen and the presence of the air in the rectum, indicating a sentinel loop sign, which is normally seen in patients with acute pancreatitis. Colonic dilatation, again it is indicative of colonic obstruction. So X-ray abdomen and chest X-rays gives a lot of idea. Ultrasound in again easily accessible, important in biliary and hepatobiliary disease, pregnancy where we cannot do X-rays. We can evaluate ovary and testicular other organs. In trauma, we can go for hemiperitoneum and aneurysm evaluation. This is showing a thickened wall, the sludge in gallbladder suggestive of acute cholecystitis. Lastly, the imaging CT is the ultimate today what we are doing every time, which is diagnostic of choice for various vascular diseases, for obstructions, for appendicitis, for neoplasm. This is one of the CT showing in acute pancreatitis. There is edema and non-enhancing pancreatic head with peripancreatic stenting. So, if the patient permits and the hemodynamic is stable, then still we can progress to the stage of CT. But otherwise, I'll just end here and say that acute abdomen is a common complaint. We have to start with a good history, location, examination, giving importance to the age, gender, and comorbidities. Basic investigations like ECG, X-ray, blood, and the abdominal X-ray can make us most of our diagnosis to locate the site of obstruction and to make further diagnosis of vascular disease, meaning assess the severity, a CT, and ultrasound for hepatobiliary disease and pregnancy. Thank you.
Just for the benefit of students, few very important points which Dr. Rajat mentioned, that at least in middle age and elderly acute upper abdomen, keep in mind the cardiorespiratory causes, look for them, rule them out. Always expose the groin for not missing out a small hernia, especially in an obese female, a small femoral hernia. Even if you examine carefully, you may miss it, so you have to keep that in mind, because still hernia is one of the common causes of intestinal obstruction. Rectal per vaginal examination is very, very important. I am sure Dr. Priyanka will tell us, young female who presents with shock and pallor, and you feel bogginess in one of the fornices, the diagnosis is certain that there is a ruptured abdomen. Also, if the appendix is mainly pelvic in position, you may not have any abdominal signs. You will elicit only tenderness on per rectal examination, which will then confirm the clinical diagnosis. Examination of the urine is very important. A female, where you think it is acute appendicitis, but urine shows a lot of pus cells, would change your diagnosis to urinary tract infection. Lactate and LDH, UDG, lactate is important, especially again in middle-aged and elderly patients, to rule out a vascular, eccentric vascular episode, which would necessitate usually emergency intervention. Pregnancy always has to be kept in mind. Young female patients in reproductive age group, because one of the pregnancy-related complications is important. And then the usual sequence of investigations. Thank you, Raja. Thank you very much. Now I request, I think we take the pediatric first. So Dr. Ramesh Darwa will tell us what are the causes, specific causes of acute abdomen in children, which we have to keep in mind. And as Dr. Maheshwari pointed out, small children may not be able to give the accurate history, they may not be able to give complete history. So how do we use examination more than the history to reach at the diagnosis in children?
Good afternoon, senior faculty members and dear colleagues. Myself Dr. Ramesh. So my topic is acute abdomen in children. As Dr. Rajat already mentioned about the acute abdomen, that is a clinical syndrome characterized by rapid onset of signs and symptoms indicating either intra-abdominal or extra-abdominal or systemic pathology that requires prompt decision making and often emergency surgical intervention. Majority of pediatric abdominal complaints are relatively benign, like constipation, gastroenteritis, but we should look for danger signs also to rule out life-threatening conditions. So clinically, abdominal pain falls into two categories: visceral, that is planktonic pain, and other one is parietal pain, that is somatic pain. The difference between visceral and parietal pain is the location of the receptor. Visceral pain are serosal surface in the mesentery, within the intestinal muscle or mucosa of the other organ. Whereas parietal pain arises from direct noxious stimulation of the parietal peritoneum, like right lower quadrant at McBurney point in appendicitis or diaphragm in splenic rupture. Afferent fibers of visceral pain are unmyelinated C fibers that enter the spinal cord bilaterally, whereas the parietal pain transmitted through the A delta fibers to the specific dorsal root ganglion. Characteristic of visceral pain is it is a gradually onset, dull acting, and localization may be imprecise, whereas the parietal pain is sharp in nature and is more intense. Other entities, referred and radiating. So referred pain felt in the remote area supplied by the same cutaneous dermatome as the diseased organ. So it is divided into either because of extra abdominal lesion, pain referred to the abdomen, like lesion in thorax or spines, or intra-abdominal but extraperitoneal origin, like pancreas and kidneys. Radiating pain is basically originated from the primary side and it radiates to the secondary side also because of common nerve root supply. Like cholecystatic pain radiates to subscapular area, splenic injury radiates to shoulder, pancreatitis pain radiates to back. Causes of acute abdomen in pediatrics are divided according to the age group. So in neonatal period, the common causes are necrotizing enterocolitis, obstruction, malformation with ramulus, and idiopathic or drug-induced like endomycin and steroid-induced intestinal obstruction. Age group between 1 month and 2 years, intussusception, infantile colic, urinary tract infection, gastroenteritis, intestinal obstruction, trauma or abuse, pneumonitis, lower down pneumonia, gastroesophageal reflux, and worm infestations are the common causes. Age group between 2 to 11 years, appendicitis, gastroenteritis, constipation, trauma, viral hepatitis, worm infestation, peptic ulcer diseases, pancreatitis, pneumonia, abdominal tumors, pyelonephritis or cystitis, and testicular torsions are the common causes. If we talk about pediatric group, the most common medical cause in pediatrics is acute gastroenteritis, whereas surgical cause is appendicitis. This table is showing distinguished feature of acute abdomen in pediatrics in different clinical conditions. Like gastroenteritis pain is acute or gradual in onset, mainly at periumbilical area, Most of the medical condition, the association between pain and vomiting is in medical condition, emesis is followed by pain, where in surgical condition, this is the pain first followed by vomiting. Appendicitis pain is acute or gradual in onset. The location of appendicitis pain is very important. Initially it started at the periumbilical area, but later on it localized to right lower quadrant. It refers to the back of pelvic area. Pancreatic pain is very acute, sharp and constant in nature. Other clinical features are nausea, cysts and marked tenderness. Intestinal obstruction pain is acute or gradual in onset. Location at periumbilical or lower abdominal area. Quality of pain is alternating cramping and painless period will be there. Intussusception pain is also acute in nature at periumbilical or lower abdominal area. It is cramping in nature with painless period in between. Characteristic of stool is red currant jelly. Lactose intolerance, there will be history of recurrence with the intake of blood products, and the pain is at the lower abdominal side. Quality is cramping in nature, and other clinical signs are distension, gaseous, and diarrhea. In neonatal period, necrotizing enterocolitis is the most common life-threatening emergency of GI tract in newborns. Risk factors are prematurity, aggressive, enteral feeding, and intrauterine hypoxia. Triad of NEC blood findings are severe metabolic acidosis, refractory thrombocytopenia, and hyponatremia. In spite of best supportive care, 10 to 30% chances of mortality are there in necrotizing enterocolitis. Infantile colic is found in up to 20% of infants. According to the Rome score criteria, age group up to 5 months we can label it as an infantile colic. Child is crying, fussing, which causes distress to the pain. The pathophysiology of infantile colic is not known, but there are certain theories like non-gastrointestinal cause, like behavior causes altered parent-child interaction or immaturity of skinniness. Gastrointestinal causes like development of lactose intolerance, altered gut microorganism, immaturity of entry nervous system, or cow milk proteins are the certain theories. Main treatment after excluding the organic causes, reassure and counsel the parents that this is a benign condition and resolves spontaneously. Intussusception is the most common cause of acute abdomen in infant and preschool children. The peak age is 5 to 9 months. There is a one segment of intestine, that is a proximal segment, which is telescoped into the adjacent distal segments. Causes are most common causes swollen pair cases, that is more than 90% of cases this is the common cause, and most common reason which is affected is ileocolic reason. Triad of intussusception is there will be a colicky abdominal pain, red currant jelly stool, that is hematochezia, and there will be a sausage shaped palpable mass. Constipation, approx 3% of all OPD visits pediatrician will face of constipation. The area, it is a kind of visceral pain located at left iliac fossa, and before labeling the functional constipation we have to rule out acute organic causes of constipation. So this is Rome 4 criteria for functional abdomen. So child must have to go more of the following criteria for at least 1 month, like less than 2 bowel movements per week, with at least 1 episode of incontinence per week if toilet training, history of stool retention, history of painful bowel movements, large fecal mass present in the rectum, and history of clogging of toilet or large diameter stools. Then worm infestation, Ministry of Health and Family Welfare with CDC, they have showed the data in 2015 that is showing that in India the worm infestation is between 12.5 to 85%. In South India it is minimum, that is 12.5%, and in Bihar it is maximum 85% worm infestation in pediatric age group. Common intestinal nematodes are roundworm, that is Ascariasis lumbricoides, webworm, that is Trichoeris saichoria, bookworm, Encyclopedia Ruminant and Heterodermis, and pinworm and protease. Other entity is non-specific abdominal pain. So non-specific abdominal pain, there is no organic cause of pain abdomen. The prevalence of non-specific abdominal pain in Western world is 4 to 10%. The associated factors like psychological comorbidities like stress and anxiety, social problems, and other non-specific somatic symptoms like fever, chest pain, and other things, they can contribute to non-specific abdominal pain. The childhood non-specific abdominal pain is considered to be a complex, time-consuming problem and is hard to reassure the parents. What are the peritoneal signs of a surgical abdomen? So, if child is having severe pain, child's eyes are anxiously open during the examiner's palpation, patient is motionless, absent bowel sounds, extreme tenderness to palpate, guarding rigidity and rebound tenderness is present, or if there is a pain with the movement or cough, then it is a case of surgical abdomen. And if child is having shock, then consider severe pancreatitis, trauma, ruptured spleen, spontaneous bacterial peritonitis, secondary peritonitis, urosepsis, associated severe GI bleed, ruptured fallopian tubes, pulmonary embolism. So, as after taking proper history and physical examination, according to the probable cause, we have to order investigation, as Dr. Rajat already discussed about the investigatory part. So, this is the algorithm for evaluating the acute abdomen. If child is present with the acute abdomen emergency, but he is not having non-specific findings, so non-specific findings, no tenderness, no distension, with or without fever. So, and child is not dehydrated, taking orally well, and no need to do anything, give oral medication and send home. If child is dehydrated, not taking orally, then start IV fluid, observe for 24 hours. If non-abdominal diseases like diabetic ketoacidosis, HUS, other clinical conditions, then we have to treat specific disease. If child is having acute or surgical abdomen, point tenderness, diarrhea with distension, bilious vomiting, peritoneal signs, bloody stool or palpable mass, then we have to consult with the surgeon, and if needed, emergency surgery is required. If there is an uncertainty in the diagnosis, but child is sick, then we have to take surgical consultation, admit the child, observe, start IV fluid, IV antibiotics, stabilize the child hemodynamically and respiratory wise. If condition resolved within 24 hours, then send home. If there is a worsening, then reconsult with surgeon. And if there is no betterment in 24 hours, then further evaluation is required. So take home message is, in the acute surgical abdomen pain, generally pain proceeds vomiting, while in the medical condition, it is the vomiting followed by pain. Considering a differential diagnosis by the age group is a logical approach, as the differential is for acute abdomen was in pediatrics. Not all the children presenting with acute abdominal pain require investigations. Investigation should be guided based on the history and physical examination. Thank you.
Thank you, Dr. Ramesh. A very important point which Dr. Ramesh mentioned is the observation. It means keeping the child under your eyes, under your care, at least for some time, and see whether the child is improving and can be sent home, or is worsening and requires further evaluation, including investigations. Dr. Ramesh, since necrotizing enterocolitis is the most severe condition in children with very high mortality, what are the early indicators when one should suspect that this child may be having NEC?
The requisites are if child is preterm, and if there is a child is not tolerating, if child is not tolerating pills, is having vomiting, abdominal distension, and there is a discoloration in the skin. So these are the early indicators that the preterm child would have necrotizing enterocolitis in next 24 to 72 hours.
So if we are suspecting NEC, what will be the line of investigation?
Line of investigations would be CGC, to look for thrombocytopenia, to look for high counts, CRP if there is a bacterial inoculation is there or not, and also BBG to look for the metabolic acidosis. Abdominal X-ray is advisable, and for management part we have to insert NG, and we have to keep the child NPU and start supported treatment, IV fluid, IV antibiotics, because chances of bacterial translocations are very high in these particular cases. So this is the line of.
What will be the choice of antibiotics if we suspect NEC?
We should start with first line, third line cephalosporin, ceftriaxone, and if we are suspecting that NICU there or even these are resistant to ceftriaxone or not, then according to the antibiogram, we should escalate the antibiotic like meropenem and teicoplanin according to the clinical condition as well as laboratory parameters and according to our antibiogram in NICU.
Thank you. Thank you very much. One question which I would like to ask Dr. Rajat, that there are situations where we have a patient with acute abdomen, but we don't find too many signs in the abdomen on examination. So what are the conditions which we should suspect?
Yes, sir. So if we are having a patient and he is having acute abdomen, so first of thing in elderly patients with cardiac disease, we should always think of acute mesenteric ischemia. In those settings, the patient do not have much of the signs. Even in patients with acute portal vein thrombosis, SMV thrombosis, so arterial as well as venous insufficiencies, they will have pain and less of signs. Some systemic causes like in diabetic ketoacidosis, then other sickle cell crisis. So in those diseases also the abdominal signs will be absent and the patient will have a lot of pain. So we have to look at the setting and then evaluate them.
Ajay, have we recently seen, are we recently seeing more of these mesenteric vascular episodes as we used to see earlier?
Yes, I agree that recently after the COVID period, there was a dramatic increase in the number of the mesenteric skin patients. Actually, the young population, if we used to think sometimes of simple obstruction, they are coming with ischemia. And almost always when we get a lactate, then when the patient comes to emergency, we find that it is high on CT scan, we find that it is usually a venous thrombus. It is more of a venous thrombus after COVID that we are seeing. I think if I see, if I remember that, I don't have exactly the data numbers, but it is almost 10 times increase. It's a very high incidence of venous thrombosis. And as we know that there is increased incidence of cardiac patients, young people having a cardiac death. Same way now I think there is an increase in the number of the bowel ischemia, which is leading to a severe complications.
So next we move on because there are several gender-related causes of acute abdomen, especially in relation to the genital tract. So I request Dr. Priyanka to tell us what is specific about acute abdomen, especially acute lower abdomen in female patients.
Good afternoon everyone, senior faculty and my dear colleagues. Firstly, I would like to thank Dr. V.K. Kapoor sir for having, and Dr. Sanjeev Maheshwari sir for having us here. I would like to cover the topic given to me, acute abdomen in females. So let's talk about the causes specific to the age group. In premenarche age group, that is before the menses have begun, the main causes are the first imperforate hymen, transverse vaginal septum and the cervical agenesis. Mainly these patients come with a complaint of primary amenorrhea. So these girls are menstruating, but because there is some problem in the passage, the menstrual blood gets collected in the uterus. So they present with acute abdomen pain, and which is cyclical, which comes every month. But it is severe. It can cause very severe pain, and it might lead to urinary retention as well. So these causes like imperforate hymen, transverse vaginal septum, and cervical agenesis. These can lead to hematometra and then the acute pain. Now, then comes the women of reproductive age group. The main causes can be pregnancy related. Pregnancy related causes can be ruptured ectopic pregnancy, which I will be talking in detail in my later slides. One of the main causes is septic abortion, especially in peripheries, where the proper aseptic precautions are not being taken, and the patient goes into sepsis after the abortion, and then patient have purulent discharge, and she comes in sepsis and the severe pain. Then patient can have endometritis, which can be again postpartum or post-abortion. Then the causes can be because of infection. One of the most common cause, which is generally mostly observed in our OPDs, is pelvic inflammatory disease (PID) and tubo-ovarian abscess. It can be because of PID or tuberculosis also. Tuberculosis is one of the genital tuberculosis is one of a very common reason for these tubo-ovarian abscess, and patient can have acute pain because of these abscess. Then third comes the complicated ovarian cyst, there is an ovarian cyst which can lead to torsion is there is twisting of the pedicle, ovarian pedicle, which can cause severe pain to the female. The ovarian cyst can rupture. There can be hemorrhage in the ovarian cyst, or there can be ovarian hyperstimulation syndrome. Generally, this occurs in patients of infertility who are being treated with the ovulation-inducing drugs. So, patient, because of hyperstimulation, sometimes patients respond to it very severely, and there can be the symptoms like pain, ascites, and worsening of the general condition. Then comes complicated fibroid. There can be the degeneration of fibroid and the torsion. Sometimes patients are pregnant and patient does have fibroid in the uterus, which can lead to there can be red degeneration in the fibroid, which can lead to pain during pregnancy. And if a patient is not pregnant, it can lead to cystic degeneration or sarcomatous degeneration, which can be responsible for the pain. And if there is the fibroid is subserosal, it can twist again. It can be there can be pain because of the torsion. Now, in postmenopausal females, there can be the causes of acute pain can be again the mass can rupture, or there can be hemorrhage inside it, or pyometra. Pyometra can be because of benign conditions or because of malignant conditions like in CA cervix. Because of the collection of the pus in the uterus, there can be pain, or in senile endometritis, senile postmenopausal patients, the pus can be because of the stenosis of the cervical os. There can be pyometra, and patient can have again pain due to the distension of the uterus as well as the urinary retention. Now, there is a systematic approach to this pain. The main objective is to rule out the urgent life-threatening conditions and the fertility-threatening conditions. So, urgent life-threatening conditions can be ruptured ectopic pregnancy or the ruptured ovarian cyst. And the fertility-threatening conditions can be PID and ovarian torsion, and it can lead to the loss of the function of the ovary, loss of vascularity of the ovary, and loss of the fertility. So, they need to be addressed first, and main objective is to address them. Now, as told by Dr. Ajay, by Dr. Rajat Bhargav, the main emphasis should be on history and the examination. History includes same age, site of pain, location, onset, duration, radiation. Mainly in gynae patients, the pain is lower abdomen pain. If there is hemoperitoneum, it can lead to shoulder pain as well because of the hemoperitoneum. The frequency, aggravating and relieving factors. Is there any history of sexual contact? Associated symptoms like nausea, vomiting, urinary retention, or any treatment given. Detailed menstrual and obstetric history is very, very important. Sometimes we get the references like patient is having severe anemia and patient is having pain and ascites, and they are being evaluated for like 2-3 days, and then suddenly somebody asks the menstrual history. Patient doesn't give the history of this period also, but there is if we take the detailed menstrual history, then we come to know that she had the history of delayed menses, or there is history of scanty menses. Then we come to know, oh, it might be a ruptured ectopic. Then we investigate her further, and we come to know it is a ruptured ectopic. So detailed menstrual and obstetric history is very, very important in these females. So not even gynecologists, even the general physicians and the general surgeons, they should also take, in a female, they should also take detailed menstrual and obstetric history. Sometimes patient can have the abortion or delivery, which can lead to sepsis, and which can lead to uterine infections and can lead to acute pain. Then physical examination, again important, the vital signs. Patient can have tachycardia, patient can have hypotension because of hemoperitoneum, because of hypovolemia. Perabdominal examination is again important. Pelvic examination is also very, very important. The diagnosis is generally made in gynae conditions on the just examination. There is the perspective and the vaginal examination. As I mentioned in pre-menarchal patients, there is hematometra, and especially in perspirate hymen, there is, if we do a local examination in these patients, or per rectal examination, because PSCV we cannot do in young patients. So we come to know there is a bluish tinge of there is a bulging of the membrane of the hymen. So we come to know that there is a collection inside the vagina. We can make the diagnosis that it is in perforate hymen. On per vaginal examination, if we do a bimanual per vaginal examination, there is a tenderness, there is a cervical motion tenderness, there is soft, the uterus is soft. So we can make the diagnosis that there might be a pregnancy, or there is an adnexal tenderness. So there can be, it can be because of the ovarian mass or ovarian torsion. So we can make a provisional diagnosis only on the basis period of investigations and the management. So now coming to the investigation, first we should do unique pregnancy test according to the history. Even if there is a patient or there is a patient who is not complaining of missed period, but we still and we are suspicious of ectopic pregnancy, then we should always do a unique pregnancy test or a beta HCG. We should always send blood for beta HCG because semen is more sensitive than urinary beta HCG, and it is usually positive 3 to 4 days after implantation. That is on the 21st day of the menses it comes positive, 21st or 24th day. Vaginal swab has to be sent for culture and sensitivity in case of any discharge per vaginum, if they are suspecting any pelvic abscess or endometritis, postpartum or post-abortum. Other routine blood tests can be sent, then on radiology is also very important. Now, ruptured tubal ectopic pregnancy, there is a triad of acute pain abdomen, which is mostly in 95% of cases, period of amenorrhea in 60 to 80%, and other features can be associated. The classic triad is present in 50% of patients. TDS should be conducted immediately. The uterus is generally empty without any gestation sac, and there is a presence of adnexal mass with free fluid in the pouch of Douglas. Management is urgent surgical exploration followed by self-injectomy with either open or laparoscopy technique. Now, PID is the most common gynecological cause of acute pelvic pain. Often presenting complaints include fever, mucopurulent discharge per vaginum. On examination, there will be adnexal tenderness, uterine tenderness, or cervical motion tenderness. On blood test, there will be elevated WBC count, elevated CRP, and elevated ESR. Early PID changes might not be apparent on ultrasound. Later changes, pyosalpins and tubo-ovarian abscess generally managed with IV antibiotics or drainage aspiration in case of tubo-ovarian masses and pelvic abscess. Now, the tubo-ovarian abscess, this is a radiological finding on TDS. Generally, there are bilateral dilated folding tubular structures with thickened walls and internal ecogenic fluid and debris. And on CT scan, these are the dilated tubular structures with thick enhancing walls and inflammatory standing of the surrounding fat is there. On pelvic abscess, on transvaginal ultrasound, there is a well-defined mass with thick walls and an internal fluid debris level. And on CCT, the left adnexal tubo-ovarian abscess with thick enhancing walls and complex internal fluid. Hemorrhagic ovarian cyst, there is a hemorrhage inside the ovarian cyst. There is a lace-like ecogenic pattern of fibrin strands that form as blood clots and then they retract. Management is usually generally with the IV antibiotics and anti-inflammatory drugs and analgesics. But if the vitals worsens or patient does not subside, or there is rupture or there is a torsion, then we might need to intervene surgically. If there is an adnexal torsion, there is a decrease to the vascularity of the ovary. There is on TDS there will be an enlarged ovary, the maximum diameter more than 5 cm with prominent peripheral non-ovulatory follicles and a small amount of free fluid along the inferior margin. On color Doppler there will be absence of the blood flow demonstrating ovarian torsion. Management is usually surgical. Nowadays we don't do directly the salpingo-oophorectomy. We just wait. We detort the adnexal and wait for the vascularity to reappear, or if it doesn't regain on detorsion or there is a gangrene, then we do salpingo-oophorectomy. If there is a ruptured ovarian cyst on TDS, there will be thick-walled ovarian cyst with stranding anechoic free fluid, a finding indicative of rupture. Again, management is generally conservative but treated surgically in case of persistence of symptoms. In pedunculated fibroid, there is on TDS, there will be heterogeneous slightly hypoechoic mass that is generally attached to the anterior margin of uterine fundus. Surgical management, that is myomectomy, is the treatment. This is the degenerating fibroid. Diagnostic laparoscopy is rarely needed to make the diagnosis. Now, this is the algorithm. If the patient is pregnant, then evaluate for ectopic beta HCG has to be sent, or a transvaginal ultrasound is to be done. If it is not there, then there might be a right lower quadrant pain or pain migrating from umbilicus to right lower quadrant. Then if it is there, then surgical consultation and laparotomy for appendicitis. If diagnosis in doubt, then ultrasound or CT with IV contrast can be done. If there is a cervical motion tenderness or uterine or adnexal tenderness, then suspect PID, do a TDS. If there is a pelvic mass on examination, then consider complicated ovarian cyst, complicated fibroid or endometriosis on TDS. If there is a dysuria or WBC on urine analysis, evaluate for UTI or the urine culture has to be sent. or gross or microscopic hematuria, then it may be secondary to vaginal bleeding. Consider stone kidney or stone protocol CT, and then TBS to evaluate for the other diagnosis. So concluding my summary, the most important causes are ectopic pregnancy, rupture or torsion ovarian cyst or PID. Early diagnosis is important to prevent the sequelae of delayed diagnosis. Most diagnoses can be made with history, examination, pregnancy test and TBS. Urgent life-threatening conditions and fertility-threatening conditions must be considered as a priority, and high index of suspicion should be maintained for PID when other etiologies are ruled out, because presentation is variable and prevalence is high. Thank you.
Thank you, Priyanka. So, a common diagnostic dilemma in a young female who presents with right lower abdominal pain is whether it is PID or whether it is acute appendicitis. So, for the benefit of students, can you please repeat that what symptoms or signs would suggest more towards PID rather than appendicitis?
So, most important presenting complaint in case of PID, generally if the patient is sexually active, then if it is associated with the vaginal discharge, or if the pain in appendicitis is localized to the right side, but the pain of PID is not generally localized. It is generalized lower abdominal pain associated with discharge per vagina, and she can, in case of severe PID, she can have fever, she can have the blood parameters raised, and if there is a tubo-ovarian abscess or the pelvic abscess, there can be the pain can be severe, the purulent discharge from the cervix or the cervix, and the patient can have fever, raised WBC, raised CRP counts, and on ultrasound there may be tubo-ovarian masses. But in appendicitis it is not, it is generally localized to the right abdomen. Right.
Thank you. And as you said that laparoscopy plays a very important role in
yes, sir. Laparoscopy, if everything is inconclusive, the ultrasound is also not suggestive of anything, in that case we can put a diagnostic, we can put a laparoscope, and then we can look if there is signs of appendicitis or there are signs of PID, like there may be tubo-ovarian masses. Generally tubo-ovarian masses can be when we look on ultrasound and TBS.
Thank you very much. So, as we have seen that there are several causes of acute abdomen in adults, in children, in females, which may require emergency surgical intervention. And I don't think there can be a better person than Dr. Rajesh Sharma, who, as some of you would know, is one of the pioneer GI surgeons, not only in the city of Jaipur, but in the state of Rajasthan. And he is currently the head of surgical gastroenterology at Mahatma Gandhi Hospital. So I would request Ajay to tell us the role and place of surgery in acute abdomen.
Thank you, sir. Thank you for Maheshwari, sir, all the colleagues, seniors over here to give this opportunity to discuss on a topic of acute abdomen, which seems simple, but actually is difficult. My problem starts not from this point. I am having my teacher, Dr. Kapoor, who is sitting over here. I have done my postdoc MCH under Dr. Kapoor at Sanjay Gandhi PGI Lucknow. 20 साल पहले भी उस घंटी से डर लगता था जो 8 मिनट बाद बच जाती है। आज उससे डर लग रहा है तो फिर बच जाएगी। तो अभी थोड़ा सा वो हर जगह के में बच चुकी थी, तो I would try that I will not spend more time than what has been allotted to me. और दूसरा सेकंड डर पैदा करने के लिए डॉक्टर MP शर्मा सर पास में बैठे थे, कह रहे थे मैं लगातार पूछूंगा तुझसे। तो फिर वहाँ से डर लगना शुरू हो गया, पता नहीं क्या पूछने वाले हैं, क्या हम फोड़ने वाले। So, but the topic allotted to me was surgery in acute abdomen, और जिस दिन सर ने बोला acute abdomen में बोलना है, and I made the slides on day 1, बंद कर दिया। फिर कल सर ने बोला उसमें laparoscopy और CT थोड़ा ऐड करना, and the difficult thing was slides were closed by that time. अब मेरे पास ऐड करने के लिए कुछ नहीं बचा था, मुझे लगा मुझे ही बोलना है। जैसा हमेशा होता है, सबको प्रेजेंटेशन बनाने के लिए बोला जाता है, we start taking the presentation from basic level। किसी से कहा जाए कि कैंसर कोलोन बनाना है, so you will start making कोलोन के anatomy, ascending कोलोन, transverse कोलोन, descending कोलोन, anatomy vessels यहाँ से आते हैं। अरे कास्कुलर कोलोन तो बोलो, वो लास्ट में आएगा। Same thing happened with me. I started with acute abdomen and started with everything. Now if I show you my slides, मैं इसको ज़्यादा कवर नहीं करूँगा। If I show you my slides, I think ऐसा नहीं होगा कुछ कवर हो गया, सब लोग पहले ये सब कुछ बोल के चले गए। Already been sold, already been told, appendicitis, cholecystitis, pancreatitis, same thing. So we all make the slide similar way. हम जीरो से बनाते हैं और फिर हमारा जो टॉपिक है ना वो लास्ट स्लाइड में छोड़ देते हैं and that usually don't covers our entire topic. I have many students with me also, so I will keep on interacting with you during my presentation. So ये शायद मेरे ख्याल से रजत ने शो कर दिया था what is foregut, midgut, hindgut. So if anyone of you can tell me where does the pain of acute appendicitis begin? Anyone? सब एक साथ एक जरा खड़े को बोल दो इजी रहेगा. देखो जो कम कॉन्फिडेंट होगा ना वो बैठ के बोलेगा धीरे से ताकि मैं सुना ही नहीं. एपेंडिसाइटिस का पेन कहाँ शुरू होता है? अम्बिलिकस पे. Why is it starts at umbilicus? You are correct. It is a dermatome. And then subsequently कहाँ चला जाता है वो? Right leg fossa पे. I think डॉक्टर रमेश ने इसको कवर करा था कि भाई when it originates somatic pain कहाँ जाएगा? referred pain. तो right side में क्यों चला गया? Why does it start in the umbilicus and goes at the right side? Now ये गलत बात है ना. DM gastroenterology इसमें आंसर दे रहा है स्टूडेंट्स वाले. You should come over here. That is wrong. That is cheating. ये नहीं माना जाएगा. Students, the student opportunity should be given to them. You are correct. It is actually पहले पेन हो रहा था when the appendix was getting inflamed. Now when it touches the peritoneum, now it causes the pain at the localizing site. So it comes at the right leg fossa. So that is actually what I presented. This that foregut, midgut, hindgut, and then the intraperitoneal visceral pain that is inflamed. This is the common slide which you will see in many of the books. That the small intestinal pain starts in it is the mid part, appendix right side, ureteric pain going from groin to groin. We should remember it. Without this, a patient coming to emergency, I don't think you are doing a justice in managing that patient. You should know where the pain locates. This is one side which I specifically added because ये हमें नहीं बताई जाती. We are not taught, we don't know, we don't understand what is meant by a colicky pain, what is meant by the characteristic of a pain when it perforates, what is the characteristic of pain when it has an acute inflammation. Now you see, the second slide I the most important, the second pain, the center one. कभी भी पेन को, I saw this long back, Dr. Anurag Govil हमारे gastroenterologist ने वो शो किया. पेन बढ़ता कम होता है क्या? इसका इजी लगा ना? पेशेंट ने कहा हाँ सर बढ़ता कम होता है. So it is a colicky pain. Get the point? It will increase and decrease. पेन लगातार बढ़ता जा रहा है क्या? You see the lowest graph. It is increasing. Inflammation बढ़ता जाएगा. Appendicitis बढ़ती जाएगी. Perforate होगा और ज़्यादा बढ़ जाएगा. Increase हो गया, decrease हो गया, then settle हुआ. That is the pain of mild perforation or ischemia. I think most of these topics are covered. I think I cover on to mesenteric ischemia in between because that is what Dr. Kapoor had asked in between on that also. There was something about investigations. I think my colleague Dr. Priyanka had covered some of the things. How many of you agree with the statement that a patient having pain in right leg fossa, having increased TLC counts is an ectopic or a pelvic sepsis or an appendicitis can be differentiated by TLC? Fine. Good. How many of you agree that a sonography showing inflammation or something in the right leg fossa differentiate between the three? No, it may not differentiate still. So, what is left now? So, I think it is not just the clinical examinations, it is not just the counts, there is something beyond it that we have to go so as to be more sure about the diagnosis. So, other values can be, yes, definitely always keep in mind the urine analysis because very often patient with ureteric pain will present or patient with a bladder stone can present with a pain abdomen, so you have to keep in mind of those causes as well. I have mentioned metabolic tests in that. ABG. Can anybody elaborate what I want to ask on ABG, what you would like to see in a patient with pain abdomen? ये students को या teachers को? Anybody can take that. Yes. So I think that was mentioned in between. मेरे ख्याल से students को नहीं idea होगा what is the importance of lactate. जब भी कभी ABG करते हैं, always see for lactate. Patient pain abdomen करके आए हैं, tenderness हो रही है, लेकिन lactate level है. लैक्टेट हमारे लिए बहुत इंपॉर्टेंट मार्कर होता है कि इंटेस्टाइन के बाउल का इस्कीमिया हो रहा है। जैसे डॉक्टर कपूर ने मुझसे पूछा, आई वाज टेलिंग यस वी हैव इंक्रीजिंग इंस्टेंस ऑफ बाउल इस्कीमिया नाउडेज, मेनी पेशेंट्स कम विद गैंग्रीन ऑफ बाउल। सो पहले दिन आपको पता चला आपका लैक्टेट लेवल इज वेरी हाई, मींस बाउल का इस्कीमिया हो रहा है। देयरफॉर एबीजी इज इंपॉर्टेंट। इट हैज अदर इंपॉर्टेंस आल्सो, बट दिस इज वन थिंग दैट acute abdomen should understand, that is the lactic acid level. Of course female she has covered better than what I can do, so I will not go into it, but I am very excited about it कि आपको बताना नहीं था। Of course abdominal X-ray, USG have been covered reasonably well. So how many of you agree that a patient with acute abdomen, pain abdomen who comes to emergency will get a CT scan? All those who agree that they will get a CT scan done for all, may raise your hand. Okay, all those who agree that CT scan should not be done in anyone, may raise your hand. Should not be done to anyone. So, how many of you think that there should be condition on which a CT scan should be done for a patient who comes to emergency with pain abdomen? Anybody? तो इसमें CT scan करना चाहिए, yes ना? किस में करना चाहिए? If you have any opinion, किस में? Suppose a patient comes with pain abdomen, you want to get a CT scan done, किस में आप कराना चाहोगे? Anything? घंटी बच गई। मैं तो CT scan पर आए सर्जरी में तो पहुंचा ही नहीं अभी तक। I'll take 2 minutes extra. Yes, ma'am.
The cause cannot be ruled out by any of the previous investigations.
Absolutely perfect. You find that the patient is sick, patient is having normal, can't elaborate on CT scan, counts are normal, on sonography, counts are normal, get a CT scan done. That gives a better picture. More important than that, I would like to pinpoint a patient whom you suspect to be having pancreatitis, but you are having clinical signs, you are not sure about it, get a CT scan done, that will give a clinical picture. You suspect patient is not having gas in the diaphragm, any patient with severe abdominal tenderness, CT scan is a better investigation. आपको, if you are thinking that this patient is a surgical patient, कितने surgeons हैं यहाँ पर? Can you raise your hand? I have done around, by now I have done around 800 CMEs in Rajasthan, and unfortunately surgeons are the least in number. हमेशा हमारी पॉपुलेशन कम होती है, क्योंकि हम लोग क्या होता है कि सर्जन्स कम आते हैं तो मेरी मोनोपोली हो ही नहीं पाती, मैं उनको बताऊं मेरे हम लोग ऐसे। So anyway, but anybody who comes with a surgical abdomen, get a CT scan before doing it, because that will help you. And definitely acute appendicitis is no more a diagnosis by clinical judgment, by sonography they can hint, it is the CT scan. For any patient who requires ovarian pathology, I have had patients who had appendicitis and initially diagnosed, and then subsequently we got a CT scan done and we found it to be torsion of the ovarian cyst. We have found a patient with bowel ischemia who had been diagnosed with appendicitis. So I think CT scan, MR also has a role. I am not going to those videos with MR and MRCP. These all have been covered. Yeah. I just come to, before ending this, I just come to one more thing, which was laparoscopy. Do you think diagnostic laparoscopy has a role in all? All patients with acute abdomen? In some patients. So, in which patient do you think that you will do a diagnostic laparoscopy?
Routine radiological investigations should not make the diagnosis.
So, in present era, CT scan will show you most of the patients what the disease is. मैं वापस appendicitis के एग्जाम्पल पे इसलिए आ रहा हूँ, सबसे कॉमनली appendicitis देखा जाता है या obstructed hernia देखा जाता है या फिर obstruction देखा जाता है. But if you see, we have had patients who have had diagnosis of acute appendicitis. You do a diagnostic laparoscopy. हम लोग next चीज क्या देखते हैं? हर appendix ऐसे भाग चल, he is my colleague now who was working with me in SMS earlier. भाग क्या? What is the second thing? जब भी appendix करते हो तो उसके अलावा क्या देखते हो?
PID changes, ovarian.
Yes, good. One is PID changes.
And Meckel's or
Yeah, so PID, Meckel's, ovary, that has to be seen.
Deposits.
इंसिजन जस्ट तो अपने हाथ से बताओ इंसिजन कहाँ लगाते हैं appendicitis का? बहुत सारे फिजिशियंस उनको नहीं पता. कितना बड़ा इंसिजन लगता है?
3 centimeters.
3 centimeters. So 3 centimeters incision you can't see the everything inside. So what is the easier way to see everything? It is laparoscopy. Do a laparoscopy before doing it. Thank God. So do a laparoscopy before doing a appendectomy. So when you are doing appendectomy, it's easier so that you can see the other sides as well. You can see diseases at other places as well. You can see the entire abdomen. So when we are doing a surgery for any abdominal emergency, it is better that you can do it laparoscopically. That will help you, because many of the pelvic diseases you can't see from abdominal incisions. One thing. Many of the things at the corners of the abdomen you can't see. Third thing, whenever you are doing a laparoscopy, you target your organ which you have diagnosed. Just have a look, careful look at the other side. And laparoscopy surgery definitely helps. इससे पहले दूसरी घंटे में मुझे क्लोज कर देना चाहिए. I think I have मैंने बताया yes I have made a thank you slide. Thanks everybody. Thank you. So sorry, let me answer the questions also.
Thank you, Ajay. Thank you. So basically, when we see a patient with acute abdomen, the final question which is to be answered is whether it is an acute surgical abdomen or whether it is an acute non-surgical abdomen. That means whether the patient requires surgery, say for appendicitis, say for ruptured ectopic, say for gangrene, or whether patient can be managed conservatively without any surgical intervention. So I think most of us, when we see a patient, we would be able to classify based on history, examination and routine investigations and ultrasound into three groups. One, those which are clear-cut for surgery. They will be operated. One where we know that this patient doesn't require surgery, they would be conservative. But there is a significant number which is in the grey zone, where we are not sure. And that is where, as Dr. Ajay said, CT plays a very important role in excluding a surgical cause, so that you are reassured, you can reassure the patient and the relatives that this patient does not require surgical intervention and can be managed conservatively. But all these patients who are in this grey zone, in the middle group, must be kept under observation at least for 24 hours. Again, the point which Dr. I think Ramesh mentioned, observation under our eyes, whether the patient is improving and can be discharged, or whether the patient is worsening and needs further investigation or even surgical intervention in the form of at least a diagnostic laparoscopy. So that, in essence, is the basic final decision-making management of acute abdomen. So with that, we will end the formal presentation, but I think we have a panel discussion with the MGMCH faculty and the JLNMC faculty, which Dr. Maheshwari will moderate.
First of all, I would like to compliment each and every speaker for covering their assigned topic very well. It was an interesting presentation, and especially Dr. Ajay. But on a very, very lighter mode, I would like to say, Dr. Ajay and all my surgical colleagues, surgeons are so bold. Why they are, I am just answering that why they are in majority. They think क्या जरूरत है हमको करने की? हम पढ़ने क्या जरूरत है? वो रेजिडेंट के घर से पेन आ रहा है, कोई नहीं, शाम को पोस्ट कर ले. Without touching him, आज शाम को पोस्ट करके खोल के देख लेंगे क्या है? It's just like that, है ना? Is it true?
Yeah, old synonym, very old statement. Surgeons read less, do more. Physicians read more, do less. I don't think I am contradicting anybody, but that doesn't go.
Okay, but I cannot forget Hutchinson and Hunter, which says abdominal examination starts from examination of oral cavity. I cannot forget Love and Levy, which says abdominal examination is incomplete without PR. So these two dictates are always there. It also reminds my teacher, Dr. Ganesh Chaksena, who says कि संजीव फीमेल पेशेंट का नाम बाद में पूछो, LLP पहले पूछो. I just cannot forget those dictates. I just cannot forget. Before starting the house to ask the question, I would like to ask Dr. Shyam Bhulga on the very, because surgeons are minorities, that there should be a difference. Sir, what do you think? पुराने ज़माने में कहते थे कि यार कुछ नहीं कर रहा पेट abdomen में, तो abdomen खोल के हवा लगा दो. इसका क्या मतलब है?
In the older times, we were not equipped with so many investigations. Fortunately for now that we are equipped with so many investigations like CT scan. I was in the period when I did not have a CT scan by institution. So that was the time where our list used to say exploratory laparotomy and procedure. So many times that abdomen was undiagnosed or खोलने के बाद like when we did not find anything, most of the time that appendix used to be the culprit and we used to come out with doing an appendix.
Thank you, sir. Now my next question is to Dr. Purnima Bajori. that it was my concept that PV examination per spectrum examination must not be done in unmarried female. But Dr. Priyanka has told some indications. So what are the indications where PV and PS can be done in unmarried female too?
Today also, sir, we are not doing per spectrum and per vaginal examination in an unmarried female. But we can definitely do a per rectal examination, and we have imaging technologies like sonographies which can help in diagnosing about the TO mass or the twisted ovarian cyst or acute PID in an unmarried female also. And most of the time it can be due to retention of the urine. We can just have a per abdominal examination, and a big ovarian mass or a twisted ovarian mass can definitely be diagnosed to some extent by a per abdominal examination and PR examination, and with the help of the imaging technologies.
But one indication she has told, Dr. Priyanka, that unruptured hymen can be a pain, a cause of pain abdomen.
Unruptured hymen, sir, it is visualized if a patient is put in a lethargic position or just on an examining table. The female is asked to fold her legs, and you just separate her leg and folds. The blood collection beneath the hymen membranes can be seen as a bluish membrane, and that can diagnose the imperforate.
Thank you, ma'am. Now, my next question is to our gastroenterologist, a very senior person. What is the abdominal migraine? I don't know.
Sir, abdominal migraine is recurrent abdominal pain in a children who is otherwise normal, and usually associated with anorexia, nausea, vomiting, or pallor. Exact pathophysiology is not known, but sometimes it is said it is because of saliva sensitivity or altered brain reflexes.
So, mostly it is referred to physiological pain rather than the anatomic or organic pain. Okay, thank you, sir. Now, the house, this session is open for the questions to the house.
Sir, one question to Dr. Ajay. How to approach incidentally detected venous thrombosis, rejecting venous thrombosis?
मैं सोच रहा था बच गया लेकिन नहीं बॉस मानने वाला नहीं है मतलब he was my immediate senior when I was doing my MBBS. I think the question is how to diagnose?
How to approach?
How to approach?
In case of rejecting venous thrombosis.
Okay. Now we have to understand that what is mesenteric venous thrombosis? Mesenteric venous thrombosis is basically maybe for the students it will be too heavy. It is acute and it is chronic venous thrombosis. Chronic means it is lying for a very long. Whenever there is a thrombus in any of the veins, it will form multiple collaterals around it. So once the collaterals are formed, then by that time the body is existed to this problem, primary problem. So this is not an acute emergency, so it is not an acute problem. I think what sir wants to do is when you have an acute emergency of mesenteric venous thrombosis. Acute emergency means the patient just had a thrombus, and now what happens is there is a decreased outflow of blood from the intestine to the mesenteric vein which goes into the portal. As with any other part, if you congest a vein, there will be an area of ischemia that develops. If there is an area of ischemia that develops, it will present in the form of pain in that. What we have to understand is what is the right time that we should come to know about this. Any patient with mesenteric ischemia, when he has presented with first pain abdomen, and if your X-ray abdomen, while pain X-ray abdomen showing thumbprint appearance on the bowel wall, meaning to say उनकी जो intestine की जो seal होता है mucosa के अंदर you will find there is a edematous area, जैसे वहाँ पे कोई blood clot पड़ गया हो या जब swelling आ गई, that is the first sign. This is the time when the mesenteric ischemia has led to a symptom which is not extended throughout the bowel wall and it is still localized to the submucosal area which is the first to get affected. This is the time when you start anticoagulant, patient may respond. Patient may respond without surgery. But now if you see a patient who is having a tenderness develop, means अब उसका ऐसा time आ गया है when the bowel ischemia has extended up to the serosal surface, outside surface of the bowel. इसका मतलब पूरी bowel wall has got ischemia. This is the time when you cannot manage him conservatively. This patient needs a surgical intervention. ऐसे patient के लिए there is no role of mesenteric anticoagulant we use anticoagulant to decrease the thrombus, but these patients require surgical. Then comes the question, can we, once you do a resection, can we anastomose, can we not anastomose, do we need a stoma, do we need to look for a relook laparoscopy, do we need to see for the thrombosis in the other areas, but when you do a primary surgery, resect the area which is ischemic and then you may close it and you may leave it, whatever the decision at that point in time, depending on the patient's condition. But keep it in mind, a patient who has a thrombus at one point will be another thrombus at the other sides also. And definitely mesenteric vein thrombus can extend into the portal vein. It can extend to the other mesenteric area also, so the whole may get ischemic subsequently. So after that, these patients will require a yes, 2 fires at the same time. We have any more gastroenterologists? Sure, I am not saying it. Yes, please.
जैसे mesenteric ischemia का जो पेशेंट जैसे ऐसा भी थ्रोम्बस का पेशेंट तो उसको हम एंटीकोगुलेंट देते हैं और रेस्पॉन्ड कर जाते हैं। कब हमें सर्जन को भेजना है, कब हमें कंजेक्टिव मैनेज करने का
क्यों भेजना है? कौन सर्जन आना चाहिए? नहीं, the patient is settled. If the patient is settled, I think
और प्रेजेंटिंग द केयर एंड एंटीकोगुलेशन एंड इंडिकेशन
if you have a patient with mesenteric vein thrombus, you have found thrombus in the vein, you started him on anticoagulant, patient is not having clinical signs. That's what you want to say? This patient does not require any surgery. I am telling you a graver problem. That graver problem is, the more severe problem is, you started him on anticoagulant, patient has responded, he is having a decreased pain, but he is having a localized area where he is having a mild pain and tenderness persistent. And he is still tolerating only passing fluid as a motion daily. Should you intervene or not? That is the problem area. I think Dr. Kapoor, we have been seeing this for last some time, and Dr. Kapoor can intervene on that.
So, as Ajay said, that we have to differentiate between acute thrombus and a thrombus which has been there for a long time. In an adult, if we see a thrombus in the superior mesenteric, splenic or portal vein, which has been there for some time, first thing we have to think of is a pathology in an adjacent organ. It could be following acute pancreatitis, it could be underlying chronic pancreatitis, it could even be a pancreatic or biliary malignancy causing secondary portal vein thrombosis. It could also be recurrent cholangitis causing portal vein thrombosis. Then, it is not the thrombus which is important, it is the causative condition. Because once that condition is settled or treated, the thrombus may resolve on its own. If it is an idiopathic, long-standing portal or superior mesenteric thrombosis, then this patient requires a prothrombotic workup and would most probably require lifelong anticoagulation. And as Dr. Ajay said, if there are no abdominal signs or symptoms or investigations to suggest ischemia or gangrene or perforation, then there is no surgical intervention required, but this patient has to be on lifelong anticoagulation. In acute mesenteric vein thrombosis, superior mesenteric vein thrombosis, very early if you pick it up, then you start systemic therapeutic dose, full dose anticoagulation. Patient may not proceed to ischemia and gangrene and may be saved of surgery. But most of the patients who come to us do not come in that window of first 24 hours. And they usually would have peritoneal signs. You do a contrast enhanced CT scan, you will see non-enhancing bowel wall, and that then becomes an indication for surgery where the surgeon would resect. And in most of these cases, we will not be able or we will not be willing to do a primary anastomosis. We will bring it out as a stoma and liver fistula. So we have to differentiate between acute and chronic. And as Dr. Ajay pointed out, that pre-COVID era, most busy surgical units would see 1 or 2 cases in a year. Now, almost every month, we are seeing a case, young people who come with mesenteric vein thrombosis and gangrene. So whether it is because of COVID or some people say COVID vaccine, the prothrombotic state, and that again is the explanation for young coronary artery disease also. But that is something which now we have to be aware.
Any more questions?
Sir, can you throw a little more light on silent abdomen?
Silent abdomen. Silent abdomen. The question goes to Dr. Kapoor.
Okay, I presume you mean that when we auscultate the bowel, we are not preparing any bowel activity, bowel sounds. So students, before you label an abdomen as silent abdomen, you have to listen to the abdomen for an adequate period of time. Standard is 2 minutes in all quadrants. If you are dealing with an acute abdomen, I would suggest that you listen for even longer time. And beware of a peritonitis abdomen where there is no bowel activity, but because there is abdominal bowel dilatation, which is filled with fluid and air, you could hear some sounds which are not actually bowel sounds, they are just tinkling sounds because of the movement of fluid with the phases of respiration. But in the setting of acute abdomen, a silent abdomen is a indication of grave cause of acute abdomen because it invariably indicates peritonitis, especially if you also have guarding, rigidity and tenderness, and then you have no bowel sounds, that indicates generalized peritonitis. The exception is paralytic ileus. In a patient who, for whatever reason, has electrolyte imbalance, uremia, or very severe diabetes causing even visceral neuropathy, where you have paralytic ileus. But remember, the abdomen of paralytic ileus is distended, but it is soft. It is not rigid. It is not guarded, and it is not tender. And when you do the X-ray, if it is peritonitis because of a hollow viscous perforation, you will see air under the domes. Again, for looking at air under the domes or diaphragm, don't ask for an abdominal X-ray. Ask for a chest X-ray. Make sure that the patient has been sitting, preferably standing if possible, for a few minutes before you expose the patient to the radiation, and write the chest X-ray including both domes of diaphragm, and then look carefully for free air. If the patient cannot sit or stand, ask for a lateral decubitus film. Again, make the patient in that position at least for 5 minutes, 10 minutes before you expose the X-ray. In paralytic ileus, you will see all parts of GI tract dilated. Stomach, small bowel, large bowel. You will see gas up to the rectum. And then you look for investigations, you look for uremia, you look for hypokalemia, and try to correct it.
Great, sir. Very important clinical call. Patient, if you are not able to stand or sit, then a lateral decubitus after at least 3, 4, 5 minutes should be taken an X-ray. And another clinical call is that in the paralytic ileus, the abdomen is soft, wherever in the peritonitis, the abdomen is guarded and rigidity will be there. Thank you, sir. Next, any more?
Any acute nephrotic tendinitis? Please,
Full 1 week topic. I can speak for a week for acute nephrotic, but definitely to be short and specific, first 4 weeks it's the physician's patient, after 4 weeks it's the surgeon patient. If patient requires surgery within the first 2 or 3 weeks, explain to the patient this I am doing just to attempt to save your life, it will not save this, unlikely that I will be able to save. But if it requires after 4 weeks, it is likely that you are going to do a correct surgery. More you delay the surgery, better it is for the patient. If you have to intervene in the earlier period, do it by an intervention radiologist, by a percutaneous drainage of the infection phase. So that is, I think, in glimpse I can say, but yes, it can be discussed elaborately on this.
Brother, many patients with celiac disease presenting with acute pain without any abdominal findings. What is the cause of pain in celiac patients?
A lot of time these patients are not properly following the gluten-free diet. So first of thing, their pain may be related to celiac disease. So we have to repeat anti-BTG IgA so that they may not, they are taking still the gluten. Or we have very rarely are not seeing those intestinal lymphoma, EATL, or the complications related to refractory celiac. I think they are not that much common in the population. The other causes of pain, what we think in other non-celiac patients like gastritis, glutenitis, or whatever, I think nearly this. So we will evaluate for other. Even tuberculosis association has also been seen in a lot of celiac disease patients. They are associated abdominal tuberculosis. So other things, just like general population, after ruling out the PTG, IgA, then it is refractory celiac, I think you were also not.
And there are few patients come with severe pain at all. All investigations are normal. Then we go for IgA, then on examination there is no fact. What is the reason of this pain?
PTG, IgA is also negative.
Positive.
IgA is positive. They are still taking drugs. Maybe because of other causes would be able to rule out because it basically doesn't have higher absorption and all that. So we would advise saying gluten-free diet and the other causes are proximal causes.
Just to proceed on that pancreatitis topic now, there is one message to all faculty, residents, students, general medicine, general surgery, all patients with gallstone pancreatitis should go home without his gall. If he has been admitted, try, if he is fit, operate him, get rid of his gallbladder and send him home. You should not have a second episode of pancreatitis at home. Until unless he is very sick and he needs time for surgery. Otherwise, if he is fit, you should undergo surgery.
Any more question? I would like to ask one question to Dr. Ramesh. Dr. Ramesh, बच्चों को स्कूल जाते वक्त होमवर्क करना भी बहुत बेहतर है। वो क्यों?
That is under category of non-specific abdominal pain, and that may be because of visceral hyperplasia, as sir has already explained about that. Abdominal migraine also in the same category. So whenever child is anxious or stress condition, that time visceral hyperplasia, because of visceral hyperplasia, child may be pain in abdomen, but it is not a thorny cause. So they will complain of that thing. Want to do anything. If we do investigation, all investigation will be negative. Even USC abdomen, no finding will be there. So we have to counsel the parents with the child or separately about the benign condition of the disease.
Okay, thank you, sir. Any more question? Now, the last question, as most senior clinical person with us, Dr. V.K. Kapoor. So now we have a lot of talk about the AI, and people are preparing the robotic doctors. What do you think in context with the acute abdomen? Can robotic doctor replace human doctors in acute abdomen?
Actually, even before the term AI came into use, we had so many publications on computerized diagnosis of acute appendicitis, where you have a software, you feed in what symptoms, what signs, what are the investigation reports, and the software will tell you what is the probability that when you operate, you will find an inflamed appendix. So it has been there. I think whatever little I know about AI is going to play a very, very important role wherever there is objectivity, which includes imaging. Because suppose we tell the computer that these are the findings in acute appendicitis in the last 1,000 patients when CT scan was done. And now you give it a new CT scan. So based on that knowledge, that information which is already in the memory of the computer, it will make a diagnosis or it will predict the possibility of diagnosis. Similarly, pathology. You feed hundreds, thousands or even millions of images of a disease to the software, and then you present an undiagnosed image, and based on its memory, based on its knowledge, the computer, because computer always has bigger memory and easily retrievable memory as compared to the human mind. So wherever there is objectivity, which is mainly in diagnosis based on either images, based on reports, based on symptoms, based on signs which are fed in, then AI is going to play an important role. It will also play an important role in uncommon or unusual diagnoses or syndromes. For example, nobody can remember all the syndromes, but if a patient presents with 3 different problems and you feed it into an AI software, and AI knows all the possible syndromes because they have already been fed into it, it will tell you that these are the syndromes which are likely. So wherever the diagnosis is more objective, AI will definitely play a role. But wherever it is a subjective assessment or wherever it is something to do something, then until we have that kind of robots which can even do the operation, because today what we call robotic surgery is not robotic surgery, because robot is still being operated by me. It is not that robot is doing surgery. So it will probably remain at least for some time to diagnosis only, and that also mainly in diagnosis based on images or based on data.
That is okay, sir, but can it replace a soft human touch?
No, there are few things which need your presence, like even video talk or virtual talk or video conferencing. There are few things which, as of today at least, have not been simulated. As you rightly said, one is touch, other is smell, other is the physical sensation. I don't think there is a name, like I am seeing one of you sitting here, you are here, I am also here. Same thing if I was doing on a video call, that feeling would not be there. So there are still some soft attributes which have not been simulated. Whether it will happen in future, nobody knows.
Thank you, sir. Thank you very much. Which AI cannot do? Which AI cannot do? Smell, taste, touch, and now. Now I close this session and hand over the proceedings to Dr. Sunil Gopal. Just hold on.
So before we close, two things. One is that I would request Sumit ji, whenever he comes to Jaipur, please collect copies of two of my books. One is on safe cholecystectomy, A to Z, which gives small tips as to how to keep a cholecystectomy safe. And other is a book which incidentally has the word which Dr. Maheshwari used, pearls. So it's a book called Pearls in Surgery, which is slightly different from the standard textbooks. It is based on how you should present a case in the exam and how you should answer questions related to that case. So I would request Sumit ji to collect these two copies from me and give it to Dr. Putra for the departmental library from my side. And Harish, you want to say something about?
I am Harish Israni from Marketing Department in Mahatma Gandhi Hospital. First of all, I would like to thanks to all of you who give your valuable presence in this continuing medical education program. It gives us immense pleasure to inviting you for this continuing medical education program to disseminate the knowledge for the professional seeking advanced exposure in medical science. We regularly organizing this kind of continuing medical education program, different medical colleges in different districts. It is very great honor for all of us that very senior faculties, Dr. V.K. Kapoor sir, is available today in this CME program amongst with us. We merely required any introduction. He is not a international faculty. Apart from that, very senior Professor Dr. Ajay Sharma is also along with us today. Dr. Priyanka, Dr. Rajat, Bhargav, Dr. Ramesh, all are very good faculty professors in Mahatma Gandhi Hospital. And it is a very, I would like to appreciate the very pleasure to conduct this program. And I would like to thank Dr. Sanjeev Maheshwari. मैंने जब भी सर से ना कोई भी एकेडमिक प्रोग्राम के लिए कहा है, सर ने ना बिल्कुल मतलब सोचा नहीं और हमेशा कभी भी डिनाई नहीं किया है. इस एकेडमिक प्रोग्राम के लिए भी मैं थैंक्स कहूँगा डॉक्टर संजीव माहेश्वरी सर को. He is always eager to conduct this kind of academic program in JLN Medical College. I just want to give a clap to Dr. Sanjeev Maheshwari. Thank you very much for conducting this beautiful program, and I also express my gratitude towards the esteemed guests available today. And I thanks once again to all of you to give your valuable presence for this program. I am requested to join for the lunch. And one thing I also want to highlight, which is going to be in Rajasthan. It is a very great pleasure for all of us and honor for all of us that some procedure which were earlier not happened in Rajasthan. and now they are also performing in Rajasthan. Patients need to go out of the state, far away for the other state for these kind of rare procedures like liver transplant, bone marrow transplant. Now it is also a privilege for all of for Rajasthan public also that this all procedure is conducted in the Mahatma Gandhi Hospital. Like we are doing liver transplant once in a week, and bone marrow transplant is also very frequently doing in Mahatma Gandhi Hospital. So, and the public point of view, this is advantage for public, Rajasthan public, that this is all are available in government schemes also like Chiranjeevi, RGHS, ECHS, ESIC and NWR. This all schemes are entered. So this is very beneficial for Rajasthan populations. Thank you very much, sir. And I request to all of you, please join for lunch.
On the behalf of Department of Medicine, I thank you all the delegates for coming here. And I also thank to all the team of Dr. V.K. Kapoor sir for deliberating very aspects of acute abdomen. Thank you all.